When I first came into office in 2005, Dr. Halverson had written a book entitled Epidemic of Care. There was a study done that I think is most telling. Approximately 115 physicians were given the same patient with the exact same diagnosis. What was interesting about it is back came 80 different treatments. Now clearly, some of those were effective, but by and large, many of them were not. Thus, outcome for patient poor, cost dramatic. So, among the things that Governor Ritter talked about, we're trying, but one is a panel of experts that are looking at common diagnoses and asking what is the most effective treatment, and we're not doing it based on cost. Because if in fact the treatment works better, it costs a little more, it's better than other treatments along the way in search of that ultimate positive treatment. Back pain is a perfect example, where all too often in certain segments of my state and of the country, you will find doctors who immediately resort to a surgical procedure which is very costly, yet the outcome for the patient is no better than physical therapy, would be much less intrusive, and the patient is served better. So when we talk about what Congress is doing versus what we're seeing, the frustration I think we share is we want real health care reform. It's not about health insurance reform. It's about health care reform. So things like point of service, things like getting better quality care at a reduced cost to patients is really where we think we ought to be headed.
And the 24/7 care.
Correct.
Even if it's not a doctor necessarily doing lower type procedures. Yes, Governor Markell.
Thank you, and first of all, I want to thank Governor Douglas for putting this together. I think this has been a great conversation, and I've taken very careful notes based on a number of suggestions from my fellow governors. And I really just have another question, and it has to do with long-term care. And I'm wondering whether any governors have had any particular success. It's obviously a hot issue with an aging population in our state. It's a particular issue. We've got a very rapidly aging population because we have a lot of retirees moving in thanks to our low property taxes. And there's been a lot of discussion about having people. That was a little plug. Yes, that was a little plug. I thought I was being subtle. But the point being, there's a lot of talk about having people not go into the very expensive institutions and having them serve more in the community. And yet some studies would suggest that in the end, although there's a lot of promise that costs get lowered, they're not always delivered, sort of along the lines of what Governor Bredesen was talking about. And I'd be interested whether any governors have come up with anything specifically with respect to long-term care.
Anybody? Governor Rendell?
Yeah, we've had a great success transitioning people out of nursing homes. Right now, nursing homes in our Medicaid program is our single biggest cost driver. We're a very old state. It costs us almost $30,000 a year for one person in a nursing home. For a family of three, a young mother with 2 children, it costs us about $3,200 a year in the Medicaid program. So to take that individual out of a nursing home, put them in home care is, number one, in most cases, what they prefer. Seniors prefer that. And number two, it's a significant cost reducer. There's some upfront costs in the transition, but you reap the savings fairly quickly. And by the way, Pennsylvania doesn't tax retirement income.
Maria, we have a program in Vermont called Choices for Care, and it has resulted, as Governor Rendell suggested, in real cost savings. We got a waiver from the Medicaid authorities to offer equal access to at-home care as institutional care, and we've delicensed several hundred nursing home beds around our state, which is significant in a small state, and we've saved literally several $1 million in our long-term care Medicaid budget as a result of this effort. And Ed's right, that's where people would rather be, at home, cared for by either their own family members or professionals in their home. So it has worked, it can work, and this raises another important issue, and that is flexibility, because we had to go to the folks in Washington and get a waiver and go through an onerous process of applying for it and amending it from time to time. What we really want and need, I think, from the federal government is flexibility to do it our way, and that alone will save costs.
That's an important point. And more success stories?
Yeah, let me just
to answer Governor Markell's question?
Yeah, Maria, let me add to what's been said, because to Jim's point, one of the things we did in Rhode Island is before the end of the last administration negotiated a global Medicaid waiver And the premise behind that was to allow the state to have more flexibility, more control over exactly the kinds of issues that Jack has brought up. It has been enormously successful. We're in the process of implementing it. All the savings that Ed, Jack, Jim have talked about, we are seeing the diversion of people prefer to stay in their home. There is no support mechanism, particularly for those eligible for Medicaid. We've all had to go and get individual waivers. So we negotiated a global waiver allowing us as a state to manage that, and it's been enormously successful. We're saving tens of millions of dollars. We've diverted hundreds of people. Some who were already in nursing homes didn't need to be there and chose to come out. But you need to develop within the community the support systems that are there so that you can give them the kind of support that they need to either stay in their home or an assisted living or some kind of intermediate facility. But clearly, for all of us, that's a huge part of the Medicaid expenditure, and it's going to grow as the population is aging.
Governor Heinemann.
Maria, I want to go back to where we were talking about technology, and you see this every day. You report on it in the financial sector, and several of us around the table have been state treasurers. Funding, information, all of it moves electronically, real time, every day. If any of us wanted to go online right now and find out how much money's in our banking account, we could do it. How much we owe on our credit card. If we wanted to go online right now and find out anything about health care, particularly as it relates to us individually, we can't do it. We need a comprehensive electronic medical system that connects doctor's office, hospitals, pharmacies, the entire system.
Which opens up, though, a can of worms on privacy, doesn't it?
It does, but we've got a situation going on in my state right now where we're conducting a pilot project in that regard in the sharing of information. You have to opt in. 98% of our citizens have opted in. It's up to you. You've got to say, in terms of privacy, we can provide it, and your records will be secure. But if any of us around the table today had to go see a doctor, they would start over. We can't afford that. We ought to be able to share those records. We ought to be able to share our prescription data, assuming we agree to it. And that could drive down costs significantly, eliminate duplication, and a number of things.
Following on that point, that's very real. In North Dakota, we've had people that go over to the Mayo Clinic and then to take all their records with them. Yeah, I knew you'd like that, Governor Plenty. It's a real challenge, a real difficulty. So it's not only a cost savings, it goes back to that quality of care. The point I wanted to make, though, is Governor Markell talked about or was asking about ways to save costs in long-term care. One of the things that we found is most productive and helpful in that regard is providing incentives for individuals to purchase long-term care insurance. Creates the right kind of incentives, so both tax credits on the front end as well as sheltering their assets that they can then pass on to family members is a real incentive to buy that long-term care insurance. That's very effective in terms of cost savings for the state, but also very good for the individuals and their families.
If it can be shared. If it can be shared, the insurance, it can be passed on.
Well, what it does is it, in essence, then their insurance pays for their long-term care rather than Medicaid. So it's tremendous cost savings to the state. The other types of incentives are incentives that encourage family members and others to take care of individuals, home-based care and community-based care, rather than going into institutional care. And significant cost savings can be achieved that way as well.
Yes, sir.
Maria, John Baldacci from Maine. I just wanted to point out that in all of the discussion, what seems to be lacking sometimes is about the patient themselves, the consumer, the individual, because I think we have a sense as governors that everybody's got a responsibility, including the patient. And I think bringing them into the discussion and making part of the decision-making, what we've done in our state is we've focused on primary and preventative health at the local level. We use our tobacco funds to have 34 main healthy partnerships throughout our state, which are at-home visits or primary care or preventative care. And also we've used a ITV network where people can log on to from anywhere in the state and do their own health risk assessment, sort of, and be able to, at the end of that, to be able to plug them into local resources so that, you know, while all the debate is going on, at least people begin to take tools on their own that are there, that are either free or reduced cost, and they know where it is, because there really is a lot of confusion to the layperson as to where to go for care and what care is available. So